There is a moment in a hospital room that changes everything. It is the moment when a surgeon, someone you trust with your life, tells you or your elderly parent that you need an operation. They use words like necessary and life-saving, and they speak with such certainty that it feels almost disrespectful to ask questions. But I am here to tell you, from a place of deep concern and backed by decades of surgical data, that agreeing to certain procedures without a second thought, especially if you are over the age of 65 or 70, might be the most dangerous decision you ever make. We are going to talk about 5 specific surgeries that carry catastrophic risks for seniors. I want to be very clear. The goal here is not to frighten you into refusing all medical care. The goal is to arm you with knowledge so powerful that you can walk into that consultation room and have a conversation as an equal, not as a passive participant. First, we have to understand the elephant in the room, the concept that the medical community is finally waking up to, and that is frailty. I am not talking about chronological age. I am not talking about the number of candles on your birthday cake. I am talking about your physiological reserve. Think of your body like a car. A younger person has a new engine, shiny parts, and a full tank of gas. They can handle a long, difficult journey. As we age, even if we are healthy, that engine has miles on it. The parts are worn. The gas tank might not be as full. Frailty is that measure of how much stress your body can handle before it breaks down. It is a systemic decline in your body's ability to maintain homeostasis and respond to a major stressor like surgery. I want you to remember this because all the data we are about to discuss points to one undeniable fact. A frail patient is a high-risk patient, regardless of how old they are on paper. And this brings us to the first, and arguably the most dangerous surgery on our list, major open heart surgery, specifically coronary artery bypass grafting, or CABG. This is the quintessential example of a life-saving procedure for a younger person that can become a death sentence for an elderly individual. I need you to understand the scale of this risk. A study of over 9,000 patients who underwent bypass surgery found that for patients over the age of 65, the incidence of in-hospital mortality was nearly doubled. And these were not just theoretical risks. The study showed a massive increase in real, tangible complications in this older group compared to the younger one. For seniors, there was a 21% rate of respiratory complications, nearly 4% suffered neurological events, and rates of kidney failure and gastrointestinal issues were significantly elevated. Think about that for a second. That means if you are over 65 and you go in for a bypass, you have more than a 1 in 5 chance of your lungs failing, and a nearly 1 in 4 chance of dying or suffering a catastrophic complication that will change your life forever. But why? Why is open heart surgery so particularly brutal on the elderly? It comes down to 2 things: the anesthesia and the bypass machine. To stop the heart, they have to put you on a machine that does the work of your heart and lungs. This procedure, called cardiopulmonary bypass, triggers a massive inflammatory response in the body. For a young person with a robust immune system and strong blood vessels, this is manageable. For an elderly person with stiff, calcified arteries and a weakened system, this inflammatory cascade is like throwing a match into a powder keg. It can lead to strokes, kidney failure, and a profound confusion known as postoperative delirium that can permanently lower cognitive function. One study looking specifically at octogenarians, people in their 80s, found that over a 10-year period, nearly 40% of them died following the procedure. That is a shocking statistic. It is not just that the surgery is hard, it is that the patient's body simply does not have the reserves to survive the trauma. This is not to say an 80-year-old cannot have a successful bypass, but it requires a level of perfection in patient selection and rehabilitation that is rarely discussed. Here is the good news. For many elderly patients who need coronary intervention, there is a powerful alternative to cracking open the chest. It is called TAVI, or transcatheter aortic valve implantation. This procedure involves threading a new valve into the heart through a tiny incision in the leg. While not without its own risks, it is a fraction of the trauma of open heart surgery. If a surgeon recommends an open bypass for an elderly, frail patient without even discussing the possibility of a less invasive approach, you must ask why. The days of only one way to fix a heart are over, but some surgeons are slower to change than others. The second surgery that can devastate a senior is aggressive spinal fusion surgery. Back pain is a curse of aging. It is the leading cause of disability worldwide, and I know how debilitating it can be. When you are in constant pain, the promise of a surgical fix sounds like a miracle. And so, surgeons are performing lumbar fusions at a staggering rate. In fact, the number of older patients undergoing this procedure increased by a staggering 138% in just over a decade. This is a multi-billion-dollar industry, and I am not saying the surgery is always wrong. But for a senior, it is almost always a terrible idea unless the patient is in exceptional health. The numbers are terrifying. A study of patients over 65 who underwent a minimally invasive fusion, the safer kind, found that they were significantly more likely to suffer complications and had much longer hospital stays compared to younger patients, regardless of whether the surgery was on one level or multiple. But here is the real kicker for the elderly: the bone quality. A study on men undergoing spinal fusion found that older age and the number of vertebrae fused were significant predictors of skeletal complications, meaning the bones themselves failed, the hardware broke, or the fusion simply didn't take. Imagine going through a 6-hour surgery, enduring weeks of agonizing recovery, only to have your spine collapse because your bones were too weak to hold the screws. It is a tragedy that happens far more often than you think. Before you ever agree to a spinal fusion, you have to exhaust every other option. Physical therapy, pain management, injections, and lifestyle changes can all provide relief without the massive trauma of surgery. A surgeon who pressures a frail elderly person into a fusion without making them try these alternatives is not practicing good medicine. The research shows that while a fusion might improve a score on a disability index, it often comes at the cost of a drastically extended hospital stay and a high risk of complications that can leave the patient worse off than they were before. Remember, back pain is a quality of life issue. A stroke or a failed fusion is a quantity of life issue. Next, we have to discuss the dark world of major cancer resections in the very elderly. This is a deeply emotional area. When a doctor says cancer, the immediate instinct is cut it out. We are wired to believe that removing the tumor is the only way to survive, but this is where our emotions can lead us to make catastrophic decisions. We are talking specifically about massive debilitating operations like the Whipple procedure for pancreatic cancer or esophagectomies for esophageal cancer. These are some of the most invasive surgeries in all of medicine. They involve removing and reconstructing multiple organs, and they require a level of physical robustness that most elderly patients simply do not possess. The concept here is what surgeons call futile surgery. It is the practice of performing a high-risk operation on a patient who is so frail that the surgery will not extend their life in a meaningful way, but it will guarantee that their final days are filled with pain, suffering, and the sterile, cold environment of an ICU. A study of patients aged 80 and older who underwent colectomy, a much less complex procedure than a Whipple, found that severe frailty was directly linked to a higher risk of pneumonia, heart attack, stroke, readmission to the hospital, and death. If you are frail and you undergo a massive resection, the odds are stacked against you. The data is even more brutal for colorectal surgery in the very elderly. A study using the National Clinical Database in Japan looked at patients 85 and older who underwent right hemicolectomy, a standard surgery for colon cancer. The rate of serious life-threatening complications was over 5%, but the operative mortality was just over 1%. That means 1 in 100 patients over 85 died on the table or in the immediate aftermath. Now, a 1% mortality rate might sound small, but you have to remember that these are only the patients who were selected for surgery. The surgeons knew they were high risk, and they only chose the ones they thought had a chance. The data on all patients with the disease, including those who were turned away, is likely far worse. For a Whipple procedure, the mortality rate in elderly frail patients is often cited as being as high as 10 to 20%. The alternative here is the hardest conversation to have, but it is the most necessary one. Sometimes, the right choice is palliative care. It means saying, I am not going to let this disease kill me in a hospital bed, gasping for air and hooked up to a machine. I am going to live out my days with dignity, free from surgical pain, and surrounded by the people I love. This is not giving up. This is choosing quality over quantity. It is accepting that the cure is worse than the disease. If a surgeon cannot give you a concrete, statistical likelihood that the surgery will give you a long, good quality life, you should seriously consider walking away. The fourth deadly surgery is elective joint replacement. I want to make a distinction here. If you fall and break your hip, that is an emergency. You have to have that repaired or you will die. That is a given. I'm talking about elective joint replacements, the kind you schedule for your arthritis because you are tired of the pain. I know how tempting it is. You see the commercials, you see your neighbor walking a marathon 3 months after their surgery. It looks easy. But for the elderly, especially the frail elderly, it is a gamble. It is true that for some people, hip or knee replacement can be a godsend. One large study found that total hip replacement was associated with a 41% lower risk of all-cause mortality and a 41% lower risk of major cardiovascular events. That sounds amazing, but we have to look under the hood. That same study showed that these protective effects diminished with age. The benefit was huge for people in their 50s, less for people in their 60s, and even less for people in their 70s. And if you look specifically at nonagenarians, people in their 90s, another study found that there was no significant difference in mortality between those who had an elective hip replacement and those who had an emergency one. The elective surgery did not provide a survival advantage, it just put them through a massive operation. What does that mean in practical terms? It means that if you are an elderly person with a high level of functional dependence, meaning you can't do your own grocery shopping, you need help getting dressed, you use a walker, the surgery might kill you or leave you with a complication that makes your life worse than the arthritis did. The trauma of the surgery, the blood loss, the anesthesia, and the grueling physical therapy required afterward can be too much for a body that is already struggling to keep up. Consider this. A study comparing the outcomes of spinal fusion in older patients found that one of the strongest predictors of a bad outcome was a high modified frailty index. The same logic applies to joints. Are you frail? Do you have underlying heart disease, lung disease, or kidney disease? If the answer is yes and your joint pain is manageable, the risk of the surgery likely outweighs the benefit. Surgeons are famous for wanting to fix mechanical problems. An orthopedic surgeon sees a bad knee and thinks, I can replace that. But they often don't see the bad heart, the bad lungs, or the bad brain that is attached to that knee. Finally, and this is the one that often surprises people, we have to talk about emergency abdominal surgery. This is not an elective surgery, it is a life or death situation. For a young person, a burst appendix or a blocked bowel is a common, treatable problem. But for an elderly person, it is often the beginning of the end. The statistics for emergency abdominal surgery in the elderly are some of the most grim in all of medicine. One review of the literature found that the 30-day mortality rate for emergency abdominal surgery in patients over 65 can range from 12 to 33%. That means 1 in 3 patients who go into the operating room for an emergency belly operation will be dead within a month. Why is this so dangerous? It is because these surgeries often happen when the patient is already in a severely weakened state. They are dehydrated, their electrolytes are off, and their bodies are already fighting a massive infection like peritonitis. Furthermore, the surgery itself is often a huge undertaking. I am talking about things like an emergency colectomy for diverticulitis or a laparotomy for a perforated ulcer. The risk of the patient not surviving the initial hospitalization is incredibly high. The risk of them dying within the first few months is even higher. The key here is prevention and aggressive early treatment. The data shows that the number one predictor of a bad outcome in emergency surgery is the patient's condition going into the operation. If the patient has functional dependence or dyspnea, meaning they are short of breath or require assistance with basic daily tasks before the emergency occurs, their risk of a heart attack, stroke, or death skyrockets. So, if you are a senior, you need to be proactive. If you feel a twinge of abdominal pain that is severe and different from anything you have felt before, you need to go to the hospital immediately. Do not wait for it to get better. Do not tough it out. By the time an elderly person presents with a perforated bowel or a burst appendix, their window of opportunity has often already closed. They are already too sick to survive the surgery. So here we are. We have talked about 5 deadly surgeries for seniors: open heart, spinal fusion, major cancer resections, elective joint replacements, and emergency abdominal surgeries. I want you to leave here with a powerful message. It is not about never having surgery. It is about never agreeing to surgery blindly. You must become an advocate for yourself or your loved ones. You must walk into that consultation room with a list of questions and demand real specific answers. The first question is the simplest, yet most people are afraid to ask. What happens if I do nothing? You need to understand the natural history of your disease. Will you die in 6 months if you don't have the operation? Or will you just be in pain? If the answer is the latter, you have time to consider your options. The second question is crucial. What is my risk of major complications, and what do those complications look like? Do not let them get away with, there's always a risk. Pin them down. Say, Doctor, based on my heart health, my lung function, and my frailty score, what is my specific risk of a stroke, a heart attack, or ending up in a nursing home? Their answer will tell you everything you need to know. The third question is about the alternative. Is there a less invasive option, and why are you not recommending it for me? Whether it is TAVI for the heart or a different approach for the spine, there is almost always a less invasive option. You need to understand why they are choosing the nuclear option over the scalpel. Fourth, ask about the recovery. They will tell you about the hospital stay, but you need to ask, what does my life look like 3 months after this surgery? 6 months? Will I be able to walk? Will I be able to think clearly? Will I be able to live independently? And finally, ask about the concept of prehabilitation. This is a non-negotiable for anyone over 65. Rehabilitation is the process of preparing your body for the stress of surgery. It is not just about showing up on the day of the operation. It is about physical therapy to build up your muscle strength, nutritional therapy to ensure you have the protein reserves to heal, and medical management to get your heart and lungs as healthy as possible before they go under the knife. The data shows that patients who engage in rehabilitation have drastically lower complication rates and recover much faster. If your surgeon is not talking to you about rehabilitation, they are not doing their job. I know this is a heavy topic. I know it is scary. We are talking about our parents, our grandparents, and ultimately ourselves. But I want you to understand that true empowerment comes from knowledge. You can no longer afford to be passive in the face of a surgical recommendation. You must have the courage to say, let's slow down and let's think about this. A surgeon's knife is powerful, but it is a tool of last resort. For the elderly, it is often a weapon of mass destruction. Do not let fear of the disease push you into a treatment that is worse than the illness itself. Remember, never agree to this does not mean never have surgery. It means never agree to a surgery without a fight. It means never agree without demanding the data. It means never agree without exhausting every conservative option. It means never agree until you have asked the hard questions and listened to the answer, not just the hope. The operating room is a dangerous place. For a senior, it is the most dangerous place on earth. Go in with your eyes wide open and do not let anyone close them for you. This is your life, your body, and your right to choose wisely. Thank you for listening, and please share this information with someone you love. It might just save their life.